Imagine a medical emergency where the absolute gold standard textbook definition of the illness is just, well, it's completely useless to the doctors trying to save a child's life.
Yeah, it's wild to think about.
Right, because usually when we think about a medical diagnosis, there's this, comforting expectation of precision. Like if you break your arm, the x-ray shows a jagged white line, the doctor points to it, and you move forward.
Exactly. It feels like engineering. It's tangible.
But today, we are taking a deep dive into a stack of pediatric nursing guidelines, historical case studies, and modern clinical protocols to uncover a completely different landscape.
And it really is a different landscape.
It is. Our mission today is to explore the art and science of assessing pediatric dehydration, specifically how clinicians actually read fluid loss in a child. Because spotting it, as we found in the sources, is less like reading a straightforward lab result and much more like playing a really high-stakes detective game.
Oh, absolutely. And the stakes in this particular game are incredibly high. The clues clinicians have to work with can be remarkably subtle or, as we'll see, sometimes outright deceptive.
Deceptive is a good word for it.
Yeah, I mean, we are talking about a condition where the difference between a child safely going home and, a child going into shock, it can hinge on recognizing a pattern of tiny, almost invisible physical details.
Okay, let's unpack this. Because before we can figure out how nurses and doctors spot dehydration in the chaotic emergency room, we have to understand why kids are so uniquely vulnerable to it in the first place.
Right, the physiological baseline.
Yeah. Like if you've ever had a stomach bug go through your house, you know the adult might just have a miserable weekend on the couch.
Just binge watching TV and sipping ginger ale.
Exactly.
Yeah.
But that exact same virus can knock a healthy toddler completely flat, like to the point of a hospital visit in under 24 hours. Why is the crash so much faster for them?
Well, it basically boils down to four fundamental physiological differences between the body of a child and the body of an adult.
Okay, what's the first one?
The first piece of the puzzle is their overall body composition. So an infant's body is roughly 70 to 80% water by weight, whereas an adult's body is sitting closer to 60%.
Wow, 80%. That's a lot of water.
It is, but the crucial detail isn't just the sheer volume of water. It's where the body chooses to store that water.
Okay.
In young children, a much larger fraction of their fluid sits in what we call the extracellular compartment.
Extracellular meaning outside the cells.
Exactly. It's the fluid circulating in the blood plasma and resting in the microscopic spaces between the tissues. It's not locked inside the cells themselves.
Reading the sources, that felt to me like having your emergency water supply sitting out in an open bucket in the yard rather than like locked away safely inside a vault. It's just incredibly easy to lose.
That is a perfect way to visualize it. I mean, because they are growing so rapidly, children need that fluid highly accessible to transport nutrients and build tissue.
Right, they need quick access.
Yeah, but the trade-off is vulnerability. That extracellular fluid is the very first thing to drain away when a child starts vomiting or, suffering from diarrhea.
The bucket just empties out.
Exactly. Now, pair that open bucket with the second factor, which is their body surface area to weight ratio.
Okay, so they have a lot of skin for their size.
Yes. Children have a massive amount of skin surface relative to their total mass, and this exposes them to what the medical field calls insensible losses.
Insensible losses, meaning what, the fluid your body leaks out without you even realizing it's happening?
Yeah, precisely. Sweating is part of it, of course, but think about how your own body reacts when you have the flu.
You get hot, you breathe heavy.
Right. Your temperature spikes and your respiratory rate increases. When a child has a fever, their breathing can skyrocket to like 30 or 40 breaths a minute.
Wow, just panting, basically.
Yeah. And every single one of those fast, shallow little breaths is carrying water vapor out of their lungs and into the room. They are literally breathing away their fluid reserves. That's wild. But wait, so they are losing fluid through their skin and their breath, but shouldn't their internal plumbing just compensate for that?
You would think so, yeah.
Because if I stop drinking water, my kidneys eventually clamp down, my urine gets dark, and my body holds on to whatever it has left. Why doesn't a baby's body just shut the outflow valve?
Yeah, that brings us to the third massive vulnerability. Infant kidneys are physically immature.
Oh, so they literally can't.
Right. The nephrons, which are the microscopic filtering units inside the kidney, they haven't fully developed their ability to concentrate urine.
So they don't have that adult conservation mode.
No, an adult kidney is a master at conservation. It detects a drop in fluid volume and immediately stops wasting water. An infant's kidney simply cannot concentrate urine to that extreme degree.
So even when they're drying out, it just keeps going.
Exactly. Even when the child is dangerously dry and desperately needs to hold on to every drop, their kidneys just keep flushing water out into the diaper. Geez. If we put all this together, it paints a pretty terrifying picture. A toddler with a stomach bug is essentially a tiny, poorly sealed water balloon left out in the hot sun.
That's a grim but very accurate analogy.
The water is all near the surface in that extracellular bucket. It's evaporating rapidly through fast breathing, and the internal kidney valves are too immature to stop the leak.
Yeah, and that brings up the fourth point, which is almost painfully obvious, but so critical when you are assessing a patient.
Which is?
Dependency. I mean, a 1-year-old cannot get up, walk to the sink, and pour themselves a glass of water when their brain registers thirst.
Right. They can't just help themselves.
No, they are entirely dependent on a caregiver recognizing the problem. And when you stack those 4 physiological realities on top of each other, high water content in a vulnerable space, massive surface evaporation, leaky immature kidneys, and total physical dependency, you understand why the timeline from healthy to critically dehydrated is so incredibly compressed in pediatrics.
Which brings us back to that massive paradox I mentioned right at the start, the textbook definition of dehydration.
Ah, yes. The maths.
Because if you open a medical textbook, dehydration is defined purely by math.
Yeah.
It's the percentage of body weight lost as fluid. Mild dehydration is a 3 to 5% loss. Moderate is 6 to 9%. Severe is anything over 10%.
Right.
So, like, if a healthy child weighs exactly 10 kilograms on Tuesday, and they come into the clinic on Thursday weighing 9.1 kilograms, they've lost nearly a liter of fluid. That's a 9% drop, placing them in moderate to severe territory.
It is a beautifully precise, objective, flawless mathematical standard.
Wait, hold on. I have to push back here.
Yeah.
How is a triage nurse in a chaotic urgent care clinic actually supposed to use that?
They can't.
Right. Nobody weighs their perfectly healthy kid on a medical grade scale 3 days before the vomiting starts. You almost never have a baseline weight.
And you've hit on the exact reason why clinical practice had to completely drift away from the textbook definition. The gold standard is a ghost.
A ghost. I like that.
Yeah, because you lack that acute pre-illness weight, dehydration in a real-world setting isn't a hard lab value. You can't just draw blood and definitively say, oh, this child is exactly 7% dehydrated.
So what do?
Diagnosing it becomes a probabilistic clinical judgment. The medical community had to figure out a way to replace the missing number on the scale with symptom-based scoring systems.
Right, so we had to rely on those bedside detectives, the nurses and doctors physically looking at the child for clues. But diving into these historical nursing guidelines, it turns out that for decades, the medical community was actually searching for the wrong clues.
Yeah, they really were. For a very long time, medical students and nurses were taught this massive, completely unvalidated laundry list of physical signs to look for.
Like what?
Oh, sunken eyes, a fast heart rate, poor skin turgor, dry mouth, altered breathing. I mean, the list was endless.
And none of it was proven.
No. Nobody had actually done the rigorous statistical math to figure out which of those specific signs reliably predicted a true 5% or greater fluid deficit. Clinicians were just guessing based on tradition.
Wow. But that all changed around 1997, right?
Yes. Enter Dr. Stephen Gorelick and a landmark study published in the journal Pediatrics.
Okay, so what did Gorelick do?
Gorelick and his colleagues decided to systematically test all those classically taught traditional signs to see what actually held up to scientific scrutiny.
They actually put the list to the test.
Exactly. They took that long, messy laundry list and stripped it down. And they discovered that there were only 4 true independent predictors of clinically significant dehydration.
4 signs out of that whole massive list.
Just 4.
Okay, let's walk through what actually survived the test. What are the 4?
So the first is prolonged capillary refill.
Capillary refill, meaning when you press on the skin.
Right. If you press firmly on a child's skin, say on their fingertip or their chest, you push the blood away and the skin turns white. When you let go, it should flush pink again in under 2 seconds.
And if it doesn't?
If it takes longer than that, peripheral perfusion is suffering. The body isn't pushing blood to the edges.
Okay, that's 1.
The second sign is the absence of tears when the child is crying.
No tears. Got it.
The third is dry mucous membranes. So looking inside the mouth to see if it's tacky or parched. And the fourth is an overall ill general appearance to the examiner.
So if you are a clinician and a child has all 4 of those signs, The probability that they are significantly dehydrated is incredibly high.
Very high, yes.
And if they have none, they are very likely fine. That 4-point framework became the Gorlick scale, right? Which is basically the ancestor of the modern clinical dehydration scales used in ERs today.
Exactly. And what is fascinating about scoring systems is how they adapt to their environment.
How do you mean?
Well, you can contrast the fine-tuned Gorlick scale with the World Health Organization scale. The WHO system is just 3 tiers: no dehydration, some dehydration, and severe dehydration.
That's super simple.
It is, because it was purposely designed for rural clinics and refugee camps. Places battling catastrophic diarrheal mortality with very low resources, it prioritizes ultimate speed.
But in a modern ER, you need more detail.
Right. In a well-resourced hospital, clinicians need the finer grain scales. They need to confidently discriminate between the child who can safely go home with a bottle of Pedialyte versus the child who is quietly slipping into danger and needs to be admitted for an IV.
Here's where it gets really interesting for me. What about the classic signs every parent hears about?
Oh, the myths.
Yeah, like checking the soft spot on a baby's head or pinching the skin to see if it stays tented up. Why did those make Gorlick's top 4?
Well, it isn't that they are total myths, but they are deeply flawed mechanisms that fail spectacularly under real-world conditions.
Okay, break that down for me. Let's look at the sunken fontanelle, that soft spot on top of an infant's skull.
Parents and even some textbooks constantly cite it as a warning sign. But physiologically, the fluid volume in the body has to drop massively before the pressure inside the skull decreases enough to cause that spot to sink inward.
Oh, so it's not an early warning at all.
Not at all. It is a very late sign of significant dehydration. By the time you notice a sunken fontanelle, you are already deep in the danger zone.
And obviously, it's totally useless on any child over 18 months old because the skull bones have fused.
Exactly. You can't even check it.
What about skin turgor, the tenting test, where you pinch the skin on the belly or the back of the hand and see how slowly it snaps back into place?
Skin turgor is the perfect example of a medical test that works beautifully on the average patient, but completely falls apart at the extremes of the population.
Okay, like who?
Well, if a child is clinically obese, the extra subcutaneous fat underneath the skin acts like structural scaffolding. It masks the tenting.
Oh, so the fat pushes it back into place.
Yeah. You can pinch the skin of a dangerously dehydrated obese child, and the fat will cause it to snap back nicely, giving you a false sense of security.
That's scary.
It is. And on the flip side, if you are working in an area with chronic malnutrition, a malnourished child lacks that underlying fat and muscle tone. Their skin will always tent and look like it has poor turgor, even when they are perfectly hydrated.
And there's also the internal chemistry to consider, right? The electrolyte balance.
Yeah.
Because the sources brought up something called hypernatremic dehydration, which just sounds like an absolute nightmare to diagnose.
Oh, it is arguably one of the most deceptive conditions a clinician will face.
So what happens?
Hypernatremic dehydration happens when a sick child loses significantly more pure water than they do sodium.
So the salt gets left behind.
Exactly. Because the water is leaving but the salt is staying, the sodium concentration in their bloodstream sharply spikes. Now, we have to look at how osmosis works. The body is desperate to protect the volume of the blood so the heart can keep pumping. Because the blood is now so salty, it acts like a sponge, literally pulling water out of the child's individual cells and dragging it into the bloodstream to dilute the salt and keep the blood pressure up.
Wait, so the blood volume is being artificially propped up by stealing water from the rest of the body?
Exactly, the mechanism. And because the blood volume circulating under the skin is somewhat maintained, the skin turgor can look deceptively normal.
Wow.
Yeah, the skin feels fine, the capillary refill might even look okay for a while, but the child is profoundly, dangerously dehydrated at a cellular level. Relying on just one physical sign like skin turgor will cause you to miss this completely.
That is terrifying. It really validates why Gorlick insisted on a multi-point scale. But even those 4 validated signs aren't foolproof if you don't understand the environment.
Right, context is everything.
Let's take capillary refill. You press the skin, it goes white. You count the seconds until it turns pink. If it's more than 2 seconds, it's a red flag. But imagine a triage nurse checking this in a freezing cold emergency room waiting area in the middle of December
They are almost guaranteed to get a false positive.
because of the cold.
Yeah, capillary refill has a massive environmental blind spot. When a child is cold, their body initiates peripheral vasoconstriction. The brain senses the cold and commands the blood vessels in the hands and feet to clamp down, keeping all the warm blood in the core to protect the heart and lungs.
So the blood isn't rushing back to the fingertips simply because the body locked the doors to keep the heat inside,
Yeah.
not because the child is out of fluid.
Precisely. The refill is prolonged entirely independent of their hydration status. This is why modern nursing protocols explicitly train staff to control for the environment.
You have to warm them up first.
You either have to actively warm the child's hand first, or you check the capillary refill centrally by pressing on the sternum right over the chest where the core temperature is stable.
That makes so much sense.
Yeah.
Let's clear up one more big misconception while we are debunking things. Tears and diapers.
Ah, yes.
Because I feel like you always hear parents say, oh, well, they're crying, but they're just crying too hard to make tears.
That is a very common, very dangerous rationalization.
It's not a real thing.
No. The absence of tears during vigorous crying is not a normal physiological variant. When the body's total fluid volume drops, it goes into survival mode. It begins rationing water, actively shutting down non-essential fluid production.
And tears are non-essential.
Exactly. The lacrimal glands that produce tears are deemed non-essential. If a child is crying vigorously and their eyes are dry, they are genuinely volume depleted.
Wow. And what about the wet diapers? You know, people panic like, oh, diaper's been dry for 4 hours. We need to rush to the ER.
A single dry diaper in isolation means almost nothing.
Really? Nothing.
Yeah, it could just be a normal variation in the child's schedule, or the caregiver simply missed a recent void. Clinicians don't panic over one snapshot in time. They look at the urinary trend over a full 24 hours, and then they synthesize that with the mucous membranes, the activity level, and the capillary refill. You cannot play detective by looking at just one footprint.
Okay, so we've covered the detective work, you've looked at the right signs, you've controlled for the freezing cold waiting room, you've checked the mucous membranes, and you've accurately spotted the dehydration.
Right, the assessment phase is done.
Now we have to shift from assessment to intervention. And this part of our deep dive is wild because it covers a stunningly simple, low-tech global miracle side by side with some seriously high-stakes mathematical rules.
It really spans the extremes of medicine.
It does. Let's start with the low-tech miracle. Oral rehydration therapy.
It is, without exaggeration, one of the most significant medical advances of the 20th century.
And where does it start?
The narrative begins with cholera research in South Asia during the late 1960s and early 1970s. Cholera is a brutal disease. It causes catastrophic, massive diarrheal fluid loss.
Like liters and liters a day.
Yes, and at the time, without prompt, massive intravenous fluid treatment, the case fatality rates in these outbreaks were frequently 20 to 30%.
That's huge.
Patients were dying of profound dehydration and electrolyte collapse within mere hours.
And 5e fluids were incredibly scarce, right? Especially in crisis zones or rural areas.
They were virtually impossible to deploy at the scale needed. But researchers, including scientists like Dilip Mahalnabis and Norbert Hirschhorn, were studying the microscopic cellular mechanisms of the human gut lining.
And they found a workaround.
They discovered something incredible. They found that even during severe cholera-induced diarrhea, when the gut is forcefully expelling fluid, the intestinal lining can still absorb water if you give it the correct biochemical key to unlock the cellular doors.
And that key is sodium-glucose cotransport. I love how the sources describe this. It's essentially salt and sugar holding hands.
That is the exact mechanism. If a severely dehydrated child just drinks plain water, it often goes right through them because the normal absorption pathways are wrecked by the infection.
It just washes right out.
Yeah, but if you provide a precisely balanced solution of glucose, sugar, and sodium, they bind to a specific transport protein on the intestinal wall. They are co-transported across the barrier together.
The way they follows them.
Exactly. As they cross over into the bloodstream, osmotic pressure forces water molecules to follow right behind them.
They trick the cellular doors into opening and drag the water inside like a tail. You are literally hacking the body's cellular pumps to bypass the diarrhea.
And this theory was tested under the most unimaginable pressure. During the 1971 Bangladesh Liberation War, millions of refugees fled into camps.
And a cholera outbreak started.
A massive cholera outbreak erupted. There were nowhere near enough IV bags, needles, or trained medical staff to save the dying, so Dr. Mahalanobis made the radical decision to deploy this oral rehydration solution, ORS, directly into the camps.
How did they even make it?
They just mixed clean water, table salt, and sugar in massive drums.
And the mortality rate plummeted.
It dropped from that horrifying 20 to 30% down to under 3%.
That is unbelievable.
Using a solution that costs literal pennies to manufacture and requires absolutely no needles or electricity, the World Health Organization took this formula and scaled it globally. It has saved tens of millions of children's lives. It is the ultimate masterclass in applying first principles physiology to solve a real-world catastrophe.
It's an incredible triumph. But, of course, there are limits. Sometimes a child is vomiting so violently they just can't keep the ORS down, or they are too lethargic to swallow, or they're already sliding into shock.
Right, and in those cases, you have to establish an IV.
And this brings us to the math. Specifically, the Holiday Cigar Rule from 1957.
Right. Malcolm Holliday and William Cigar published a seminal paper linking a child's caloric expenditure to their baseline fluid needs. They created a mathematical formula that translates body weight into an hourly IV fluid rate.
And that's what we call the 4-2-1 rule today.
Exactly. It's mentally calculated on nearly every pediatric floor in the world.
I want to walk through this math together because I want you listening to feel the friction of what an ER nurse is doing at like 3 in the morning. Let's say I bring in a 15-kilogram preschooler who is severely dehydrated and needs an IV.
Okay, 15 kilos.
How do you figure out how fast to run the drip?
You break the child's weight down into chunks. For the first 10 kilograms of their body weight, the rule dictates they get 4 milliliters of fluid per kilo per hour.
Okay, so 4 times 10 is 40. That's 40 milliliters an hour.
Yep.
But my kid is 15 kilos. We still have 5 kilos unaccounted for.
Right, so for the next 10 kilos of weight, or in your case, the remaining 5 kilos, the rule drops to 2 milliliters per kilo per hour.
Okay, 2 times 5 is 10. So I take the 40 from the first chunk, add the 10 from the second chunk, and I arrive at a total IV rate of 50 milliliters per hour.
You got it. The math itself is simple, but here is the trap, and it is a major source of medical errors.
What's the trap?
What's fascinating here is that 50 milliliters per hour you just calculated, that is purely maintenance fluid.
Maintenance meaning just what the child needs to exist?
Exactly. It covers their basic metabolic needs while lying motionless in a hospital bed breathing, making basic urine. It is completely 100% separate from the deficit fluid.
The deficit is what they already lost.
Right. The deficit is the liter of fluid they already threw up before they even arrived at the hospital. That deficit still needs to be calculated and replaced on top of the maintenance rate.
Oh, wow. So the nurse is actually running 2 completely separate parallel mathematical equations. One to keep the baseline steady, and a totally different calculation to replace the massive deficit.
Yes. And if you conflate the two, if you just calculate the maintenance math and think you are done, that child stays dangerously dehydrated.
The complexity of fluid management in a chaotic environment, it's just an incredibly delicate balancing act. It requires constant vigilance.
It really does.
Which transitions us to the dark side of this history. Because math errors are not the only danger in that 5E bag. The actual chemical makeup of the fluids we use to rehydrate children became the center of a massive, tragic medical controversy.
The great fluid debate.
Yeah, and it proves that good intentions can cause deadly mistakes, and more intervention isn't automatically safer.
There is a deeply ingrained assumption in our culture, both among patients and sometimes clinicians, that if someone is sick and dehydrated, pushing more 5E fluid is always the safest bet. Just hydrate them.
Right, pump them full of fluids.
But the history of pediatric 5E fluids proves how catastrophic that assumption can be when we ignore the body's stress responses.
Let's dig into this debate. Hypotonic versus isotonic fluids. What was the standard nursing practice for decades? And what was the logic behind it?
So for roughly 50 years, the global standard was to put hospitalized children on hypotonic maintenance fluids.
Hypotonic meaning what?
Hypotonic means the IV solution has a significantly lower sodium concentration than the child's own blood plasma. It is mostly free water.
Why did they do that?
The rationale seemed perfectly logical in 1957. Doctors looked at a healthy child's daily nutritional requirements, noted that a healthy kid needs much more free water than sodium on a normal day, and formulated the IV bags to match that everyday ratio.
But a child lying in a hospital bed with a severe infection or recovering from surgery is not having a normal day. Their internal chemistry is completely altered.
Fundamentally altered, sick, stressed, or nauseous children experience a massive surge of antidiuretic hormone, or ADH.
ADH, okay.
Yeah, pain, fear, and nausea trigger the brain's survival mode. The brain releases ADH, which aggressively commands the kidneys to shut the gates and hoard every drop of free water they can.
So you have a child whose body is chemically locked into hoarding water. And then the medical team connects them to an IV, pumping in hypotonic fluid, which is loaded with massive amounts of extra free water.
And that excess water has nowhere to go.
Because the kidneys won't let it out.
Right. The kidneys refuse to excrete it because of the ADH surge. So the free water builds up and massively dilutes the sodium concentration in the child's bloodstream. This causes a condition called hospital-acquired hyponatremia, dangerously low blood sodium.
And that messes with osmosis again.
Exactly. Because the blood is now so watery and diluted, it forces that excess water into the body's cells to try and balance the pressure.
Including the cells in the brain.
Yes. The brain cells absorb the water and begin to swell. But the brain is encased in a rigid, unforgiving bone skull.
Oh no.
That swelling cerebral edema has nowhere to expand. It compresses the brainstem, causing seizures, permanent neurological damage, and in tragic cases, death.
That is horrific.
Throughout the 1990s and 2000s, horrifying case reports began accumulating, particularly in the UK and Canada. Previously, healthy children coming in for routine surgeries or moderate dehydration were dying. And they weren't dying from their original illness. They were dying from the hypotonic fluids they were given in the hospital.
Iatrogenic injury, meaning the medical treatment itself was the weapon. That is a terrifying thought for any parent or nurse. How long did it take the medical community to react to this?
It took years of fierce debate, but eventually the pile of evidence became undeniable. Health authorities began issuing urgent safety alerts.
Did they finally change the rules?
Finally, yes. By the mid-2010s, there was a massive systemic pivot. Major pediatric guidelines around the world completely reversed course. They abandoned hypotonic fluids for routine maintenance and shifted the default protocol to isotonic fluids.
Isotonic meaning it matches the blood.
Exactly. Isotonic solutions closely matched the actual sodium concentration of human blood, preventing those deadly osmotic shifts.
So the medical field finally stopped trying to match what a child needs on a healthy day and started matching what a child's blood actually needs on a sick day to keep their brain safe.
Exactly the shift. It was a monumental change in standard nursing and medical practice, and it was built entirely on a foundation of documented harm, rather than just abstract physiological theory. It is a sobering, permanent reminder to the medical community that dehydration treatment is a delicate biochemical balance, not a brute force, more is better intervention.
So bringing all this complex physiology and history together, why does reading fluid loss in a child matter so much to us outside the walls of the hospital?
It matters because this is not a solved historical problem. It is still one of the most pressing active health crises on the planet. Globally, diarrheal disease remains one of the absolute leading causes of death for children under 5.
Still today.
Still today. And the vast majority of those children are not dying from the viral or bacterial infection itself. They are dying from the resulting dehydration. That is why continuing to teach caregivers in low-resource settings how to recognize those 4 key physical signs and how to mix that simple oral rehydration solution continues to save lives on a massive scale every single day.
And it's not just a global health issue happening far away, it's a local one in every community. In wealthier nations, dehydration is consistently a top reason for pediatric emergency room visits. You get the winter virus surges where rotavirus and norovirus tear through daycares, and you get the brutal summer heat waves where kids are sweating buckets, burning through their extracellular reserves, and lacking the dependency to drink enough.
Every single time a sick child is assessed, the stakes represent a tightrope walk. If a clinician or a parent at home under-recognizes the dehydration because they are waiting for a late sign like a sunken fontanelle, that child can easily slide into hypovolemic shock.
Their blood volume drops so low their vital organs are starved of oxygen.
Right. But if you panic and overtreat them, if you demand unnecessary IV fluids for a child who is only mildly dehydrated and could just drink ORS, you expose them to the pain of needles, the risk of hospital-acquired blood infections, and as we just saw with the hyponatremia tragedy, the very real danger of catastrophic fluid mismanagement.
It all circles back to the very first thing we talked about today, the expectation of clean, mathematical precision versus the messy reality of the clinical detective game.
It really does.
So what does this all mean? Looking at all these sources leaves me with one final lingering thought for you to mull over. If the absolute gold standard textbook definition of this illness, comparing a pre-illness weight on a scale to a sick weight, is totally impractical in the real world, and if the most effective world-changing medical treatment ever invented for it, oral rehydration solution is just a rudimentary mix of salt, sugar, and water hacking a cellular door, what other areas of modern high-tech medicine might we be wildly overcomplicating? What else out there is better solved by simple, rigorous observation and trusting basic human physiology?
It is a profound question to walk away with. It proves that sometimes the most sophisticated life-saving answer is actually the simplest one.